normal movement of the intervertebral disc. When the disc gets degenerated, this disc now doesn't go up and down, it doesn't give the shock absorber effect, and it collapses. When this disc collapses, what happens is the spine, which is so stable, it starts moving front and back. So this is the sequence of events which occur when the spine gets degenerated. In order to stop this happening, the nature is trying to control this. The nature can control like anything, like callus formation and everything. When there is a movement occurring, the nature tries to stabilize it. The stabilization occurs with bone and the soft tissues. So the osteophytes starts coming and it starts giving the stability to the spine. Now this is what happens when it goes down. Here it is what you can see. When it goes down, there is a new bone formation which occurs. This bone formation which occurs, these are the osteophytes which occur at the ends of the bone. And these osteophytes, along with the ligamentum hypertrophy, tries to stabilize this spine. And this is, in a nutshell, the degeneration. If it stabilizes, which occurs in large majority of the people, in aging people, this occurs and there is nothing, which is a normal aging process, continues, occasional aches and pains. This disc, when it collapses, obviously with the aging process, the height of the person reduces to a certain extent, and this is the normal situations how the degeneration continues. And when the degeneration continues, as you can see it here, this osteophyte formation occurs, and the spine which goes on moving in flexion extension views, you will be able to demonstrate this mobility of the spine. If it has not succeeded in stabilizing with the osteophyte, the degeneration, the osteophyte formation and the hypertrophy all occurs simultaneous. And if it happens simultaneously, things are stable and nothing happens. All what you will see in the older people's spine is a few osteophytes here and there, and they are not the cause of the problem. The osteophytes is not the cause of the problem, that is the nature's way to try to stabilize the spine. When it doesn't stabilize, when this continues the movement, then the symptoms will occur. And then in the MRI, you will see this space is gone because this is degenerated. As you can see, this is the normal disc space, this is the normal disc space, this is the normal disc space. And when the disc space degenerates, the degeneration is occurring, the hypertrophy, osteophytes are forming, the ligamentum flavum is hypertrophy, and ultimately the spinal cord gets compressed, and this is the typical degenerative spinal canal stenosis. And this is what is the end results in these people where the nature doesn't succeed. Now this is the spinal stenosis. You can see the changes which are occurring. The disc space is getting degenerated and the osteophytes will start forming here. And due to instability, the nature tries to stabilize with the new bone and the hypertrophic tissues. And this new bone formation which occurs, the ligamentum flavum hypertrophies and the spinal cord gets affected. If stability is achieved, no symptoms. If stability is not achieved, then the baggage due to persistent instability, and this can be controlled by decompression when there is a spinal canal stenosis is occurring. And stability if achieved, new bone formation all over and gives claudication pain as the space needed after the walking to when you walk about the new bone for new blood formation occurs in the paraequina, it gets the space which is normally available. But when it happens into this space which is crowded with these osteophytes and ligamentum flavum hypertrophy, the spinal canal stenosis occurs. Because when the person starts walking, when there is a there is the blood flow occurs in the spinal cord. There is not enough space for the spinal cord to expand, which normally is available. When it is not there, and it is because of this, the osteophyte formation, it gets constricted, and that's the reason why the patient typically gets pain on 20 minutes walk, and he starts getting pain mainly in the legs. That is the typical spinal canal stenosis. Once we see this spinal canal stenosis is occurring, there is a slowly increasing situation. The nature is trying to stabilize, it hasn't stabilized, the hypertrophy, the deep instability, and the distance also goes on decreasing. Initially it may be half an hour to 45 minutes, and then it slowly goes down to 10, 20 minutes or 15 minutes, whatever it is. Instability also gives backache and claudications, as all of us know about it. Two typical scenario after degeneration. Stability, no pain, all is well. Because this is what is the normal, each one of us are aging process which is occurring, this happens. Occasionally, elderly people get pain. Early morning back pain which occurs when the muscles are relaxed. Once you start doing your activity, the pain goes away and everything becomes normal. And that is what is the normal aging spine. All of us who are aging, we do get these occasional aches and pains in the back in the early morning when we get up from the bed, and at times it creates a problem. And if the degeneration has occurred and instability has occurred, then the pain increases, the claudication. If the stability is compromised, the cord compromised, stenosis symptoms, and all these things typically continues. If healing but no stenosis, it is normal, happening in majority of us. Few of others, nature's attempt at healing gives stenosis. If these osteophytes are forming, it may give complete stability, but this osteophytes is going to be into the spinal canal because it's going to happen all over. Then it is a stable spine, the still a claudication occurs. And that is what is it is the way that the degeneration ultimately ends up in. Only basic, no root symptoms. The treatment is exercises, belt, query I will put it, because belt does help in the early phase when there is a pain, or I will put it the other way. Like to me, if I get an early morning pain and I am going for a golf, I have found out because I was a constant person who said the belt is useless. I used to say that the belt is useless, though I would advise the patient because they want it. But I realized that I can play golf comfortably if I am having a belt on me. Immediately after the game is over, I can remove the belt. So the belt does give some stability temporarily for whatever it is, and that is the only reason why the belt is there. Otherwise, generally, belt is not the major issue. The issue is the exercises. If the symptoms are more and you desire relief, then obviously the fusion. I am talking about where there is only the backache but no root pains. And they all are disc replacement. So there are two scenarios. There is a backache, there is an osteophyte, there is a constant backache which is occurring, there is no claudication. If that person desires a relief of that back pain, then there are two things which occurs. This is the typical, if there is an arthritis which is occurring here, as you will see, this is arthritis which is occurring, and this is the only giving is the back pain. Then people like Gautam go ahead and do this replacement of the disc. This replacement of the disc is supposed to give stability, and it gives this mobility, and this is still at the moment it is a debatable surgery. There is a debate among the spinal surgeons whether this is useful or it is not useful. Still is a different thing. But this is the thing which is there purely for the backache. It is not for the root pains. Or for the root pains, if it is there, then obviously the fusion, either interbody or intertransverse and whatever you like, with the today's armamentarium which is available, most of the fusion done today is with the hardware. So this is, if the pain is there, either you can do the fusion or you can do the disc replacement purely for the degenerative pain in the back. If the root pains and stenosis symptoms, then this is the typical way. These are the osteophytes which are forming in the gutters, and the root decompression is the treatment of choice. So this is where you are going to decompress the root. Please see it again. Nowadays, this total laminectomy is never done. It is only these roots which are decompressed, and roots are the ones which is the problem. And so the root decompression is the treatment of this claudication. Root decompression is the must. Nowadays, the laminectomy is not needed. Only interlaminar decompression of the roots, and that is the treatment of this claudication pain. It is a typical spinal canal stenosis claudication which is occurring. And if the patient is suffering, you desire a relief, then this root canal release is the treatment of choice what is there today. The debate today is new bone formation is nature's way to help aging spine by giving stability. When claudication symptoms, this same new bone gives symptoms, and if this bone is removed, it will create instability and the return of the symptoms due to this instability. And that's the reason this is a vicious circle. If you give the stability for the help of the patient, that gives the claudication, you remove those bones and those osteophytes which is pressing on the root, and that can itself give recurrence of the symptoms of canal stenosis. And so spinal canal stenosis is known to recur due to this instability. So when only decompression and when associated fusion is the debate which I think it goes on among the spinal surgeons and peripheral spinal surgeons like me. When there is anterior bone presentation, when there is an anterior bone and it is stabilized, if there is a canal stenosis which can give stability even after posterior bone removal, only decompression is okay. While doing decompression, do not destabilize the spine with unnecessary removal of bone. Keep lamina, they are not the culprit, they are not the ones, except in a central canal, you may have to undercut the lamina partially to remove that central canal of decompression. Otherwise, it is basically the roots which is the one. Remove bone only around the root canal, which is symptomatic, and keep other useful bone to avoid recurrence of the symptoms. So today, that Christmas tree removal, laminectomy, which all of us that I am sure Gautam probably has not done it in his career. Have you done, Gautam? No. We have done it. That is what was the treatment of the day at that time. We have done that, and we have got those recurrence which occurs 5 to 7 years it would start recurring. So the treatment has changed from what we used to do it in past than today. And its stenosis is very lateral. Occasionally, inadvertently, one facet joint is fractured or removed during surgery, then the instability occurs. Because once you are doing the decompression surgery, it has to be a complete decompression. The root cannot remain really compressed. And if there is a massive bone formation is occurring in the root canal, during surgery at times the facet joint is compromised, either purposely or accidentally. And in this situation, the instability is going to be much more. In this situation, though it is claimed that only one facet joint absence does not give instability, it is better to add pedicle screw and the fusion in such cases. So today, I think the pedicle screw has become at the smallest provocation. The pedicle screw is added up onto this whenever you feel that there is a possibility of destabilizing after the decompression. As you can see here, this was the pre-operative surgery. This is in days 87, as you can see, this was done by me individually. By that time, the fusion had come, but not the pedicle screws or any of the other fixation. This is post-decompression infusion, and we had done the lateral fusion, because at that time the there, that if there is a decompression which you do and there is instability, you got to do the lateral fusion. But the lateral fusion is not enough. This is 6 months post-op. It is still the instability continues. This is the second patient, Cindy. We did this was as you can see, this is in the days of a myelogram. This is pre-op. This is what was the pedicle screw was put in. Only, sorry, there is a interdiscal graft This was a PLIF which we used to do it in those days. That had come and we very proudly we used to do this PLIF. It was a difficult surgery, not many people did it. There were no Gautam Javaris in those days. We were the spinal surgeons. And that time the pedicle screw had not arrived, and if at all we used to do the small metal at the back, but this is the new thing which had come, PLIF. We did this PLIF with the good care and everything, only PLIF, no hardware and anything, and you can see what happens. 4 years, the whole thing has started displacing and the symptoms have started recurring. And hence, canal stenosis surgery today, you got to be far more careful that you are not destabilizing it. If ever there is any destabilization, it has to be fused. And this is how ultimately it was fused. This is the days in those days when we started pedicle screws. On the other side, somehow the other pedicle screw became loose. We had to remove it into transverse fusion, and ultimately the whole thing was salvaged. I'm talking about this is about 20 years back. This is the pedicle screw. So the stenosis with instability, it should be decompressed and fused with the graft and the pedicle screw. That is the treatment of choice. As you can see here, this is the 78. This is the about 45-year-old person. This is the X-ray in 78. This is the X-ray in 86. This is a 49-year-old person, same person. This is in 88. You can see now the instability has started. This is the time when the problem continued, and then 89 when the instability was much more. So this progressive instability also occurs. But unlike lytic listhesis, it doesn't go on increasing very rapidly. It's a very slow process, and by and large it almost stops at these situations. It doesn't go on and on and on and doesn't become a very big thing. So obviously decompression and pedicle screw and the lateral fusion is a treatment of choice. If there is a whether to add up the interbody fusion or no, that is a debate which is still continuing about this, particularly spinal canal stenosis situations, whether to do the pedicle screw intertransverse graft and interbody graft to be added or no is still a debatable situation. In all these situations, the flexion extension views are the most important things. The flexion extension views are ideal. Now here you can see this is the degenerative listhesis, and it is fixed up with the fixations and everything happens, and then over the years, as you can see, the adjacent segment starts getting degeneration. If the person lives for a longer time, the adjacent segment also starts having this degeneration. There is already an adjacent segment degeneration there, and the patient started having pain after 6 to 7 years, and this is probably the cause that at that time whether this segment should have been fixed up or no is the second debate which continues in these situations. This is after 5 years. Now the long-term effect of fusion, adjacent segment changes are known in the fusion in a young age. In 60s and 70s, so it may not be that we will see them after 15 years. Probably large majority of them will pop out before that, and that's the reason this adjacent segment problem doesn't occur as often as we see it in the lytic listhesis. And here you can see intertransverse fusion also works. This is the days in which we used to do only intertransverse. It works. Intertransverse fusion will work if there is no instability. If there is an instability, the movement goes on continuing, the graft gets absorbed, and that's the reason why the intertransverse fusion or intervertebral fusion does not work. So the stability is the main part why these fusions work. All these things, even 9 years intertransverse fusions work, and here it is in the interbody fusion, it works beautifully. So all these things will work if there is no instability. If there is an instability, all this graft will get absorbed, and that's the reason diagnosing instability in this degenerative spine is the most important situations. And there are many times when we are in doubt. Even non-instrumented surgery work, but now with the introduction of the instrumented surgery, that is the most preferred treatment today. I don't think there is any debate about it. Though I am not that convinced about the cages in lumbar spine, bone graft is as good for me. I do not like to use the cages in the lumbar spine, but that is a debatable situation which I use it in cervical spine, but not in lumbar spine. In conclusion, degeneration is a fact of life. Everyone undergoes this degeneration. In very few, it gives symptoms of stenosis or packing. If it is symptomatic, if it is a root problem, obviously the root has to be released. Otherwise, there is never going to be a relief there. And when in doubt, when you release the root, when in doubt about the instability, must be added up with the fusion, at least intertransverse fusion with the pedicle screw, and that is going to give you the choice. If symptomatic, most only need decompression of the roots and cord, not conventional laminectomy. Few will need fusion. Recurrence of stenosis is about 40 to 70%. After fusion, adjacent segment problems may occur. And that's the reason this surgery for degeneration, it is a time-buying situation. And fortunately, humans die, and that is the only end of all miseries. Otherwise, the spine problem never is cured. It is only helped, and that is how it continues.